We are continuing to discuss assessment, so to talk about the concept of going that macro identifies micro, and then go into separating things. So the idea being, for some set of reasons, I need to attempt to separate between structures to see which one is most at play with the restriction that I'm going to find, especially in relation to the patient's presenting symptoms, symptomatology, or complaint. So essentially what we are simulating here is we're simulating that the patient has come in, and within a lot of osteopathic practices that I'm aware of, people will talk about pain in their sacrum or pain in their SI joint. Now, I have a few challenges with the concept of sacroiliac pain or sacroiliac joint issues because just of the actual anatomical reality of the joint, where especially once you're an adult, it does not move particularly much. I believe it's 2 to 5 degrees depending. I think there are some extreme cases where adult female gymnasts, there may be about 10 degrees of motion, which is still not a particularly large amount of motion, but it does exist. So those are outliers. All that said, patient presents theoretically or in a simulated sense with pain in the sacral region. I'm still going to check everything. So we're going to go through my general scan. We'll have you bend to your left, right, bend to your right, and in a comparative sense, we pretend as if he bent fine to the left, not as well to the right. So we have a general left side bending finding, column wide, just as a macro thing, and that would relate to some possibility of uneven loading in the sacral region, right? Possibly. So I have a large finding, I have a macro finding. We'll have you on your back. Right, so again, we just go through the general algorithm that I utilize in order to check everything to not be negligent, because if you have pain in the sacral region, there's lots of things that connect there. Right, so again, we're simulating things. Right, so we simulate, we pull across, and the left hip doesn't move particularly well across the body. Right, again, simulated finding. Right hip moves fine, so I have two things. So preference for left side bending, left hip will not adduct particularly well. Do a straight leg raise to see if there's any other findings in either of the legs. Nothing of particular note, right? So I have two findings that seem to center in around here, kind of the left pelvic lumbar region of the patient. We check the arms very broadly, looks fine. You can do that bilaterally. I tend to do it unilaterally because I can remember what the other arm was doing. We check the neck, again, to not be negligent. Right, so this is taking you through what a fairly full assessment along those lines of macro identifies micro, preferably patient active before patient passive, and being organized. Right, we'll have you flip to your front, so no finding in the neck. So now my general concern happens to be the lumbar region, the sacral region, because of patient presentation, left hip. Right, so the muscles on the left lumbar column will shorten nicely. They will not necessarily lengthen as nicely. So I want to figure out, or at least that's the large motion. I can make the initial assumption that it's the muscles, but I don't know that. So now what I want to do is essentially try to differentiate between the things. So now I need to consider the areas that I have my findings. So basically, if we were to cut the patient up, it would be kind of left lumbar column that I'm going to be at least somewhat interested in, and the left hip, and the pelvis broadly. Quick way to deal with this as far as the column is concerned and the sacrum is concerned. I take both hands, make a bar so that I'm going to contact everything. Low hand on the sacrum, broadly, it doesn't have to be in a particular place. Thumbs on the column, right? Other hand up. And I'm going to use my eyes here. Take a deep breath and let it out. Right, so high. My high hand moves fine, my low hand does not move particularly well. So in this case, what I actually want to do is I want to do a spring test, because there is something in this region that's not moving as well. I can spring into the sacrum, just generally see what it's doing, right? Then I can spring into the lumbar column, and the lumbar column has some yield, not enough. So my findings currently are leading a little bit more into the lumbar column. So The left side bending with restriction to the right actually seems to be more focused in the lumbar column. And then I just check through the hip, right? So I check through the soft tissues of the hip. When I'm checking through the soft tissues of the hip, I want to go perpendicular to fiber direction. Your hip rotator is somewhat oblique from pelvis to greater trochanter, so if you go into the space between there, broadly with the heel of your hand, you can check. So some tension there, less tension there, right? So I had 2 areas of findings which were in a similar region that are going to relate in some way to pain in the sacral region. If the left lumbar column is not moving as well, there is some uneven stress and strain on the sacral region. If the left hip is not moving as well or somewhat restricted, there are multiple tissues that are going to connect into the pelvis as well as into the sacrum that can contribute to pain states. So I actually have 2 separate findings. I have a lumbar finding and I have a hip finding or a hip soft tissue finding. So what I would do is I would then treat both of them. If I wanted to, I could then choose between the 2 as to which I thought was more of an issue, right? So I could say, well, comparatively the hip was more of an issue, and then see if I treated the hip if the lumbar column would loosen up. But in this case, because both of them are findings of note, what I would do is I would treat the lumbar column, so I would go to the soft tissue first. I would then reassess with my spring test to see if that changed the spring test. Then I would treat the hip. As far as soft tissues are concerned, then I would retest those soft tissues, then I would have the patient back into supine. So instead of going through all of that, because it's fairly packed as far as information with what we did, just understanding I went from the macro, so my large test, I had a lumbar finding, put the patient into supine, so in-seated I have a lumbar finding, put the patient into supine, then I had a hip finding, flipped them into prone to expose that so I could then peel it apart, right? Because complaint was a sacral complaint or an SI complaint. But in this case, I don't necessarily have initial findings that would suggest that it was a sacrum. I have large findings in the hip and the lumbar column that are of note, so I would definitely work on those first. If those change, and upon re-examination and a subsequent treatment, those are good and there's still sacral pain, that's when I would go into the sacrum, because the larger complaints were dealt with. So again, we go from macro identifies micro, then we go into that smaller area to try to pick them apart when we feel that we need to. And to do so, we have to isolate structures to figure that out. Once we've isolated and figured out the one that is most at play, in this case the 2, you provide treatment, you retest, and then sometimes your primary reassessment is the next visit.